Felicity, Marcella, Jasmine, Lindsay, would you please turn on your camera and join us? Oh, Lauren, remember you have to make them co-hosts in order for them to turn their cameras on.
Got it, Carlos.
So as I was mentioning earlier, we set up this conversation and we prepared with the trainees and with the students to a Global Health Summit scholar process, in which for the last 6 weeks, 4 weeks, the students and the panelists here have been preparing for this in many forms. They've been taking workshops, conversations, readings, lectures that intersect in the different components of how the decolonial mindset intersects with their future profession. So we have today representation from different learning groups within this pre-summit process that we endeavored, in which I'm going to introduce the working group and I'm going to call out the names of the people that are in the chat. I mean in the panel. So when I call out your name, panelists, please just open up your mic, say hi, and then I'll get to the questions. Okay, so I'm going to start with welcoming from the Ciheb, Zambia School of Medicine program, Dr. Seville. Hi, welcome.
Welcome. Good morning and good afternoon.
Thank you. Welcome. I'm going to see if I can find you all. Dr. Mupeta, hi, welcome.
Thank you very much, Dr. Guzmán, and I'm glad to be here. I'm still waiting to have my camera turned on. Thanks.
Okay, no worries. We'll get to you. Dr. Toake. I can't see you. Oh.
Yes, hi, I'm here. Thanks, I'm glad to be a part of the program. Thanks for having me.
Thank you. From our dental program, we have two students. I don't see Sadataka still, but Ashraf, welcome.
Hello, thank you for having me. It's such a pleasure to be here. Thank you.
Thank you. And we also have Jasmine. Jasmine, hi.
Hi, everyone. Thanks so much for having me.
Great. From our nursing program and our nursing partnerships, we have Marcella. Marcella Leith, hi.
Hi, thanks for being here. Thank you for having me.
Thanks. And we have also Felicity Omotosho from the University of the Gambia. Hi, Felicity.
Hi, it's good to be here. It's a great opportunity. I'm grateful.
It's a pleasure to have you here. From our PT program, we have Lindsay Mathis. Lindsay, hi.
I am very elated to be here. Thank you so much for having me today.
Thank you. From our School of Pharmacy, we have Janet. Janet, hi.
Hi, everyone. So happy to be here. Thank you for having me today.
Of course. And Sadataka, you just joined in time. Hi, welcome.
Hi.
Thank you for joining us. So great. We have, I think, everyone on screen. And what we'll do is for the next 50 minutes or so, we're going to engage in a conversation where I'll be bouncing off questions from the different panelists. Now, as you might recall, they've been preparing some of these questions we've discussed together, and panelists have been able to think through these questions as part of their preparation for this. So I'm going to start with our colleagues at Zambia with the Ciheb program. And I want to recall that during our workshop, as preparation for this panel, you all shared a vision of what you considered what a decolonized global health field would look like, right? What does decolonization mean for the field of global health? So let me ask you, if you're willing to kick us off by sharing your thoughts in this regard. What does decolonized global health field look? And I open up the mic of any of you three that want to take that question.
Okay, so I'll go ahead. I want to first say that this is a very important conversation to have, as we are pretty aware that global health decolonization and colonization actually is pretty extensive. The global health agenda of various major global health issues have been talked about for a while now. So I think that with global health decolonization, having the conversation around what is important in terms of people sharing ideas, discussing how to understand the cultural norms of the various countries outside of the Northern Hemisphere are important. And so it's the exchange of ideas, it's the understanding of the various countries that are visited to foster education, to foster allowing the lead of those who are there to take part in various areas of research and education, whether it's education in the area of business or medicine. We're all here in medicine. These are important things to consider for decolonization, because decolonization it's taken place over centuries. And so it's not an easy thing to just adjust and get rid of. So the fact that these conversations are ongoing, we have to really target the areas that are important to foster the countries that we're partnering with to, evolve and be better and allow them to take the lead. But in order to do that, I think that we have to take a step back and understand the cultures, the languages, the customs. These are all very important things that I think were mentioned in our conversation that we had with you last week.
Thank you. Dr. Mupeta or Dr. Seville, do you want to add anything?
Yes, I can go ahead. Dr. Sevilla here. And again, thanks for having us and inviting us to share our thoughts on decolonizing global health. I'll start by saying that on our part, who are resident in the Southern Hemisphere, decolonization would mean that we probably reach a point where some of the homegrown ideas from the low and middle income countries or underdeveloped places are brought to scale or brought to visibility. We do have some ideas, but the transfer of these ideas from this north to south is what's been happening, but probably we need to move ahead and see how we can transfer some of the ideas from the south to the north, especially in the areas of domesticating technology. I know there's a lot of technology in the Northern Hemisphere. The question when we are talking about decolonization is, can we bring some of this technology to be resident in the Southern Hemisphere? I submit. Those are my thoughts. I don't know what my colleague, Dr. Mpeta, thinks.
Yeah, thank you very much. First of all, I would like to point out one striking feature. If we look at this panel, and I think there are only 3 male, this shows a lot where, 10, 20 years ago, this panel would have just been full of men. And that's how it should be the same when we talk about, decolonization of global health, giving equal opportunities for people in, less developed countries. And I would, riding on the previous speakers in the opening sessions, I would want to point out that the majority of people resident in resource-limited countries do not necessarily want to, leave their countries. The majority, succumb to brain drain because of lack of opportunities, to advance their career or to practice their trade. So that being the case, one of the things that, quickly comes to my mind is, refining of curricula. Curriculum has definitely been so westernized, and sometimes it leaves so much in terms of what exactly happens here. And you find that you train somebody in their environment, but they are again ill-equipped to take care of their own, environment, because the curriculum has somehow been skewed to the West. There's also, it's also important to understand, the different dynamics when it comes to the practice of medicine in the West and also in Africa. And this brings about to the exchange program that we have had even with University of Maryland, which is wonderful, by the way, where we are having, students from University of Maryland coming to Zambia and vice versa. Now, this should be coupled with some practicality. And what I mean by this, if you are reading in the same program and you have got this exchange program between students, why don't we develop a dual system of courses where a certain part of, course is done in the US and the certain part of the course is done in Africa. And there's easy, that is an interchange of students where somebody knows if I'm in my second year, this type of, when I'm talking about this type of, infectious disease or something, I'll learn them from Africa, in Africa, because they are apparent more in Africa. And then if I'm going to talk about, learn about, transplant medicine and infectious diseases, then I know that that part of the course I'm going to do it in the United States because there are better transplant centers there compared to Africa. Then the other things is we look at access. We mix a lot with students coming from, University of Maryland. They have got access to their online library and immense resources, whereas us on the other side, we don't have the same opportunities. So if we are allowed to mix on a global health exchange program, why don't we also have temporary registrations in the US, university, so that we could access the resources that our friends have? And this will also, reinforce the partnership when it comes to research. We've seen a lot of our students counterparts coming here and in no time being able to do a research while you've been here where the data is and you still fail to conduct a research. So there's that need to collaborate and strengthen, the twinning of, prospective research and researchers so that we can enhance, global health, not just skewed in one direction, but it should be a bi-directional way so that we can improve the health and ensure that there's fast, transfer of technology and advancement in the area of medicine. Thank you.
Thanks, Dr. Mupeta, Dr. Tokwi, and Dr. Seville for that. And of course, you're mentioning the Ciheb program, which is an amazing program. I've heard a lot about it, which is, I do have to take my hat off to what Dr. Lottie Hachambwa and Dr. Cassidy Klassen have been doing with their program. And these are kind of just an array of opportunities or a sample of opportunities that live up to that bilaterality that you're speaking of, that sharing of not just knowledge, but also cultural traits as part of the education process and allowing the different moments in different educational opportunities for the lead to be different, right? Who is setting up and who is having the ownership of the different educational experiences at different times can swap. So it does take time, as you were saying, and it takes also a lot of trust. So these are all things that I've been picking up as you were speaking. Now, let me move the panel to our nursing group, which I know Marcella and Felicity, I know you've been thinking about this topic even before the summit started, right? Even before the summit was announced, you were thinking about how do we create more equitable opportunities. But I also know that you've been also, because of your training, you've been really keenly aware, bringing back to where I started, the COVID-19 pandemic, that there is a lot of structural inequities still that are part of these colonial legacies, right? And that we have seen emphasized by the COVID-19 pandemic. So why don't we start us off, and can you provide us some insights in this regard? So please.
Greetings to all, and I'm glad to be here. Okay, we're talking about the structural inequities. I would, in my own opinion, these are factors that are in place that tend to put a few people or a few groups or a few institutions or some organizations at a more advantaged positions than some others. And more often than not, those at the disadvantaged positions are usually the marginalized peoples or the minority groups. So this inadvertently leads to we having colonial legacies. As we all know, these colonial legacies, this is simply a process of power exertion by a stronger country on a weaker country. And in our case, it's no different because of the, our profession. We see the legacies all around us. And well, it is very important to know that these impacts have not only been negative, we've also had positive impacts when it comes to colonial legacies. So some insights I would like to share. I know my fellow colleague to Marcella, we also have some insights to share, but on my part in the Gambia, I currently reside in the Gambia. And during the COVID-19 pandemic as of last year, there were a lot of precautionary measures that were put in place that were announced by international health organizations on how to minimize transmission of COVID-19. But as we could see, many other countries, especially in the high-income countries, they announced lockdowns, they catered for their citizens, even without citizens having to work for a specified period of time. They catered for them, they brought food to them, and made sure that they were comfortable as much as possible. But that didn't apply to us here in the Gambia. Because in the Gambia, though the lockdown was initially announced, people cooperated with the government because, well, everyone was afraid, everyone was scared. So, well, let me protect myself. Government says stay indoors, and I stay indoors. So people just managed with a few, I would say, food or supplies they had. But got to a point, people revolted and said, hey, government, please let us out. This may have happened, this may have, been, well executed in some other places, but it doesn't apply to us here. You people ought to know that you should find some other strategy to put in place. Because for instance, in the Gambia, women have to go shopping every morning to the market, every morning to fend for their families, to make some food. So now you're shutting people in because, hey, lockdown measure is one of the precautionary measures and what have you. You're shutting us in where it doesn't apply to us. It can't work really well for us here. So that's one of the sociocultural factors that come in place. And when you also talk about some cultural factors in the Gambia here, people are used to shaking themselves, as in with the hand, in form of greeting. Now you're telling people no shaking, stay a few feet. That affected us a little because we couldn't hardly put that into practice here. So it brought about a very great resistance in adhering to these precautionary measures. So these are some of the social inequalities. When it comes to the healthcare system, also, COVID-19 pandemic had its own, blow on the healthcare system in the Gambia, in the sense that there was chronic understaffing, usually, anyway. Let me start by saying that long before the pandemic, public healthcare facilities in the Gambia grapple with understaffing, especially nursing staff. So we grapple a lot with it. So now the onset of the pandemic, it really showed how can I put it now? It showed our weak areas. Yes, our weak areas became more evident. Now, on the staffing, especially in rural Gambia, if in the urban area we grapple with understaffing, how much more rural Gambia is much more understaffed. So the much impact was felt even in the rural Gambia. And for instance, now in the Gambia, there's only one teaching hospital, and is the only major referral hospital. So at the time of the COVID-19 pandemic, if there were COVID-19 patients, they have to move all the way. For example, maybe in the rural places, they have to move all the way down to the urban area where the teaching hospital is located. They have to move all the way down. So that distance, so all these are all legacies that have come to play, and they have really created disparities. And we realize that, to put all these ideas, all these foreign ideas into perspective in our own setting here is really difficult. It's really, really difficult. So these are some of the structural inequities. And even when it comes to maternal health care in the Gambia, before the COVID-19 pandemic, Gambia is doing quite well when it comes to maternal health care. But at the start of the pandemic, especially when it was still the waves were still really high, well, there was difficult access when it comes to maternal health care. In what sense? Healthcare workers were more interested in protecting themselves. And I also like to mention that we grappled also with inadequate resources when it comes to PPEs, when it comes to ventilators, when it comes to, public, facilities and what have you. So healthcare workers were more concerned about protecting themselves, and it was announced that, okay, N95 is the best mask to use to prevent yourself. But hey, long before the pandemic, we didn't have N95. Hardly do we have it in our public health facility. Now we hear all of a sudden N95 is the best. But thanks to God, we are grateful that this whole pandemic brought some positives. In what sense? At least at the point in time, it was announced that, okay, people can now use local fabric to sew masks. So that gave room for indigenous innovation. So I also like to comment on that. So it gave room for indigenous innovation and on our home using our local fabric, because how can the government actually get N95 masks for a little over 2 million people in a country? That's obviously difficult. So we are grateful that at least the whole pandemic issue brought about that innovation. And it also made us to realize some weak areas. So in case something like this happens, and I also like to say something like, at 2014, when the Ebola virus hit Africa, especially Sierra Leone and all that, I don't know, most probably we didn't learn our lessons. When it comes to our settings here, because now we are seeing a repeat of such, and yet it still shows low preparedness. An article that was written, that was published, I would say recently, by Jatta et al. A research was carried out in the Gambia among healthcare workers to look at their level of knowledge and preparedness. Of course, there was a high level of knowledge among healthcare workers as regards COVID-19. When it comes to preparedness, well, there was a very low preparedness. So that article confirmed that information. So at this point, I would like to give it to Marcella. I don't know if Marcella has one or two things before I also chip in a few ideas.
Thanks for that, Felicity. And Marcella, if I may, I'm going to move it to a next question, and I know you have your thoughts here. And as we prepared for this workshop, you did signal, and the group preparing for this panel did signal that despite the ongoing efforts to diversify the nursing field, we still are seeing lack of diversity within, especially in leadership roles. Now, we can still see some exclusionary practices, and some of this takes form in the types of knowledge that are incorporated into the nursing fields. Can you share a little bit of your reflection about this on the education process, the lack of diversity in leadership? How does the nursing field then overcome these current gaps?
That's a big question, but thank you for it. I think in harking back to everything everyone else has said, the most important thing is being aware that we have this lack of diversity, that we really need to be aware. We need to look at our own systems. We need to look at who we're working with and understand that we're taking care of very diverse populations. And so as a healthcare team, we need to also represent those different populations that we care for. I think a lot of the way that nursing academically is structured might need to change. And that goes back to decolonization. I mean, we can decolonize nursing academics just like we can decolonize global health. I think there are, it's great to have these, reports from the Institute of Medicine, the National Academies of Medicine, talking about the future of nursing and talking about how we need to allow nurses to work to the full scope of their practice. And we need more PhDs in nursing. We need more nurse practitioners. But if the systems in which we're working aren't supportive of that, if nurse practitioners, if APRNs are still only going to be paid 80% of what a physician makes, if we are not going to be able to pay off our student loans, why should we go back to school to get a doctorate? So I think we need to be talking about all of those systems as well. And we need to be recruiting from populations that we don't see at the table. One thing that was really interesting the last time we met as a group was that there's no Latina representation on the nursing school faculty. So how do we get that? And I think that starts with how we're interacting with our professors on the individual level. I see racism in my classes right now. I'm a DNP student at University of Maryland at the School of Nursing, and I see my two Puerto Rican colleagues being treated very differently than the other colleagues are in my classes. And we should all be fostering each other. And I think nursing specifically has that stigma, which is unfortunate, of this lateral violence and this sort of eating our young, which also needs to be gotten rid of. And I think the way to do that is to also have younger people step up and foster and mentor the next generation to get into these higher positions in academia and in management and leadership within hospital systems. So it has to be a multi-pronged approach, and we have to look at all of the systems and how everything's operating.
Thanks for sharing those thoughts, Marcella. And it really, both of you, what you're speaking to is, and reminds me of what Dr. Nodimo Para was saying earlier, is that systems will do what they're designed to do, right? And if we keep pushing the same things into the system, the same outputs are going to come back. So we really have to have, and what I heard you both say, we really need to have a structural discussion, not just band-aids here and there, tokenism here and there. We really need to think about the systems that are perpetuating these injustices. So thanks for sharing those thoughts, Felicity and Marcella. Now, Lindsay, I know you've been very passionate, and we've had conversations one-on-one in which you've expressed that throughout your education, you haven't really engaged with conversations like this. And the excitement that you were kind of telling me about was that this was an opportunity to rethink what PT physical therapy is. Why is this such an important moment to have this conversation? And I'm glad that you reached out to me and we were able to have that one-on-one conversation. Now, for the PT profession, the physical therapy profession, context is incredibly important, right? Context is actually something that PTs are really aware of. They have a really keen awareness of what the context is, because rehabilitation is not just about the person. It's also about the context. That is, attention to the built environment and thinking about the functionality and well-being is between the intersection between person and environment. However, and I think you mentioned this in our conversation, the very profession seems to still have some areas where they've not been able to look inward, right? They're very good at looking outward, not necessarily very good at looking inward. Now, I know you're very passionate. I know you personally mentioned that you've thought that the profession needed to take a hard look at itself to build and educate for better physical therapy professionals. Now, can you share your thoughts in this regard? Tell us a little bit about your personal journey in this regard.
Can you hear me? Okay.
Yes.
Thank you for your question. I first want to say thank you to my brilliant summit team for being the blueprint to my addition to today's discussion, to my teammates Rogers, Caroline, and Promise from the University of Malawi, and my fellow PTRS mates Alyssa and Peyton. Thank you so much. So to address your question, I will be referencing a document my teammates and I created together to make sure that I capture the most important points of our discussion over the past weeks. Some reflect my personal journey, but most highlights our shared thoughts and experiences as PT students. So first, we found that analyzing the PT profession and incorporating this global health perspective reveals where PT practice is most vulnerable to inequity. Colonization and Eurocentrism contribute to significant deviations between the global North and South within our profession, whether it be historical exclusion of low to middle income country research and PT evidence, or the lack of prioritization of global health and PT education. Decolonization really begins with looking from within our profession, as you mentioned, and interpersonally, institutionally, and structurally to determine where implementation of global health is possible and how. So first, we talked about the models that we currently use to assess the entire patient in front of us rather than just focusing on movement impairments alone. So these include things like the ICF and biopsychosocial models. They're currently well-defined in literature, and we use them a lot in school and in PT practice. However, it's important to note that there are a plethora of other factors that determine how and why clinicians decide to use these models in their practice. Some of these factors include where they receive their PT education, globally and at what institution. And within an institution, what do the educators value clinically? Because sometimes PT curriculums are tailored to what educators value as clinicians. And sometimes it can be a subconscious projection of their clinical bias. Also, how a PT has treated a similarly presenting patient in the past. So a physical therapist might be more likely to use clinical experience to determine primary treatment methods. And then last but certainly not least, research is super important in physical therapy. So what research is available, where is it available, and what research, anecdotally even, is known to be the most effective for certain patient populations. So the next part of the question that I want to talk about is diversity. So one of the most important aspects to the discussions related to diversity is that it greatly depends on social and geographical context. So even within one confined city or region, the needs of diversity can change significantly. So globally, the needs will vary even more when comparing country practices. For example, in my discussion with my team, we talked about the diversity needs in Malawi related to research and how it greatly affects their PT practice autonomy and the abilities for them to specialize within the field of physical therapy. So most of the research in the PT profession, like many healthcare fields, is done in high-income countries, as mentioned earlier from other professionals, and in the global north, which leaves areas of our profession exposed and vulnerable to inequity. So implications of this that we talked about were that PTs practicing in low to middle income countries have less autonomy over treatments most relevant to patient needs in their region because other countries are deciding what the priority treatments within these regions are. Also, treating the patient holistically becomes increasingly difficult because the best available evidence, which is very limited, does not reflect the patients in that region where the research is being implemented. Also, the lack of research taking place in low to middle income countries makes it more difficult for other professionals to value a PT's role within the interprofessional team. So physical therapists often work within different parts of the workplace that involve talking to nurses, occupational therapists, speech language pathologists, et cetera. And so we want to be able to advocate for our profession, but we can't do that if the research is limited and the research is limited. So physical therapists need the local-based research, and it's very crucial so that we can advocate. So next, we can compare this perspective to the diversity needs in our profession in the US. So here, the diversity needs are most immediately related to the lack of racial and ethnic diversity in our profession, especially within the field of physical therapy, since we are one of the least diverse fields in the global north in terms of race and ethnicity. On a larger scale, only recently have institutions and legislative bodies prioritized diversity in our profession on faculties and student bodies of professional education programs and in our field of practice. And so these efforts are appropriate. However, we need to ensure that institutions are not just checking boxes to meet quotas, including PT relevant education about why diversity and inclusion is essential, and education regarding the underpinnings of why there's a lack of diversity in physical therapy. And this is what could make decolonization possible, rather teaching the roots of these manifestations rather than just simply cutting the branches off. The issue here, though, that we discussed is that the underpinnings of decolonization can become highly politicized, which results in decolonization-related efforts receiving significant pushback in many areas of leadership in the field of physical therapy. So leadership boards and accrediting bodies that are not related to special interest areas may not prioritize this lack of equity as urgent or necessary. I'd also like to add that there are plenty of students currently enrolled in PT education who are still victims of microaggression and culturally insensitive behaviors at school and in clinical environments, despite the current efforts in place to avoid these and to include more racial and ethnic diversity. All considered, It was a bit challenging for us to know exactly what algorithms are used to prioritize components of PT program curriculums, nor do we fully know the priorities of legislative bodies that implement laws affecting our practicing jurisdiction, but we as students do see and live the immediate effects of current priorities of the higher ups. And with that, we kind of came up with a small list of potential things that we can do within our profession to jumpstart the decolonization of PT. So on a smaller scale, providing opportunities of exposure to global health from the beginning of PT education. This will provide students with early experiences with global health and therefore more opportunities to integrate this lens into our didactic knowledge. Also advocating to accrediting bodies about how global health education will advance the future of physical therapy in terms of awareness and global application of research. Hiring faculty who have experience or background knowledge in global health to make the integration of global health into physical therapy education more mainstream. And then I briefly have some global things that we can do that I discussed with my team. So creating more platforms like this for students and professionals to exchange dialogue on a global scale. I personally have learned so much about PT that I never knew from class or any other clinical experience that I've had so far in school. And I can imagine that students all over the globe can greatly benefit from this exchange and dialogue. Also prioritizing funding for local research to be conducted and facilitated by professionals and researchers on the ground of low to middle income countries, giving more local autonomy to clinicians. Increasing interprofessional awareness of benefits of physical therapy to other practitioners in settings where we practice, whether it be local or government-run hospitals or in private practicing clinics. And then lastly, creating platforms for LMICs to share information and research about helpful treatments and practices they've found to be useful. Not only will this exchange increase the standardization of practice, but it'll also make us more culturally aware and competent providers. So that's what I have so far.
Thank you, Lindsay, for sharing those thoughts. And I really encourage you to try to write these down in a formal fashion so they can be heard by wider audiences beyond what is in here. And as a reminder, we do have a special edition of the Annals of Public Health, of Global Health, being published under this summit, a special edition on Decolonizing Global Health Education that a lot of these panelists will be participating in. So thank you for sharing those thoughts, Lindsay. I really heard that it's not only going from the systems, but also the small actions can also add up to change and modify how we understand the profession. And I want to give a shout out to Dr. Tori Marchesi and Dr. Kara Felter, who really facilitated a lot of this conversation with students. And from the nursing group, I forgot to mention Dr. Nancy Bolin and Dr. Veronica Naikar, who have also worked with the students and continue to work now. Kind of, it's become kind of its own momentum and movement. So I want to move it on to the dental group. And for the people listening, I want to tell you that the dental group took a little bit of a different route and went ahead, and not only did they think about how learning should happen in global health environments, but they took like a leapfrog and said, let's do the learning right ahead. Let's see how it goes. And they structured a partnership between the School of Dentistry at UMB and Nihon University at Matsudo with the help of Dr. Hanai Saito and Dino Gata at Matsudo and Dr. Kate Noonan at UMB. And what they did, they organized a peer-to-peer learning opportunity to try to establish how COVID has impacted dental education, and in the way, try to reflect upon how these educational partners happen, how these educational partnerships can be successful or not. So Ashraf, Jasmine, and Salataka, I know you've put together a small PowerPoint presentation, but mostly I want to ask you, what was the value of the collaboration between these two schools? Why is it important to set up global learning collaborations that are equitable in regards to the participation and the bilateral learning opportunities? So tell us a little bit about that.
If I may begin, thank you, Dr. Faerron Guzmán. I think the very important thing that we learned from our reflections and our discussions is that when we want to provide patient care, personalization is very, very important. And in order to personalize care and tailor our care to specific needs and cultural needs, lifestyle needs, it's very important to increase our awareness. So our collaboration with the students at Japan really helped us increase our awareness. It helped us gain perspective, not only on healthcare, but on many different cultural nodes. And so we realized the importance of expanding our horizons and creating more programs, whether it's educational, whether it's clinical, so we can do more collaborations worldwide. Because we have a diversity in the US, and even if it's not within the US, it's important to, exchange information. We had a lot of exchange of information from Japan to the US and from the US to Japan, equally great ideas coming from both sides. So I would say the most important thing is that we increase our awareness, as well as plan on future collaborations to tailor our care to specific needs, create personalized approaches, as well as to, approach everything from a global and very diverse perspective.
Jasmine, do you want to add something?
Sure. Thanks, Ashraf, for your insight into those questions. And in order to provide further understanding as to the importance of collaboration, I would just like to invite Ashraf to share our slides just a little bit, just to kind of provide more insight as to what we did. So we at the University of Maryland School of Dentistry work in partnership with students in Matsudo to kind of deep dive into the effects that COVID-19 had on our curriculum. So here's our university, as you may all know, on Baltimore Street. Now, as you can tell, our education within the dental school is mainly simulation, clinical, and didactic based. So it all kind of comes together from year 1 to year 4. And these are our partners from UMSOD. And then also our partners from Nihon University.
Thank you, Jasmine and Ash. And our school is located in Matsudo City, Chiba Prefecture, and it takes about 30 minutes to get to Tokyo by train. In Japan, dental school is a 6-year program where the students start after the graduate high school. We used to focus on study abroad before COVID-19, and we are looking forward to resume the activity. And those are the participants from our schools. Thank you.
So in order for us to further analyze the comparisons and differences between our education here in the States and in Japan, we had various different learning objectives that we analyzed. And specifically, it did focus on the changes that COVID-19 had within our different curriculums. So our approach was various literature reviews, and then also providing a survey summit to all of the various participants, both here in the States and in Japan. And the analysis that we got, or the conclusion that we got, was pretty interesting. So this is the criteria that we kind of looked into. And the conclusion was that between our curriculum changes due to COVID-19 and the curriculum changes in Japan, they were pretty similar. However, we would all like to note that we wouldn't have been able to come to this conclusion without properly asking the right questions and having greater communication between both teams. More often than not, when we want to compare, sorry, my cat is driving me crazy. More often than not, when we want to compare from the state point side of view to international point side of view, we fail to have proper communication, and we rely more on assumptions than proper communication. So yes, between the States and Japan, there were pretty similar changes within the curriculum. However, we wouldn't have found that out unless we did the proper analysis. Unfortunately, I'm not sure if you can all hear video. In conclusion, we just want to thank all of our partners here stateside from UMSOD and also from the students at Mitsudo. We thoroughly enjoyed this collaboration, and we had a fantastic time learning more about our curriculums and each other, and we hope to continue learning and collaborating in the future. I think that our little project really focused on the importance of collaboration, the importance of proper communication, and asking the right questions. You can connect it back to like humanitarian missions and things like that, where more often than not, we stateside want to provide help, want to do some type of change, but we don't often communicate correctly or ask the proper questions in order to see what the proper need is for those international sites. So by being able to collaborate in a very intimate way with the students from Mitsudo, we were able to have a better understanding of their actual changes instead of just relying on assumptions.
I appreciate those thoughts, and again, kind of reflects on how collaboration happens, some of the challenges when collaborations are emerging, usually also when there's things like language and cultural barriers, but also things as logistical as time barriers. And I know we had a kind of a difficult time even coordinating the calls in preparation because of the time difference between Japan. So when thinking about global collaborations, the flexibility needs to be baked in. And I found myself taking calls at 4 a.m., 5 a.m., because that's what it takes sometimes. If you want to provide the opportunities, you want to elevate the voices, you got to really be flexible. And I saw a lot of that from your working group. So I really appreciate the work that you've done as students and the work that your faculty has done in providing that good framework for collaboration. Now, finally, I'd like to move on to our pharmacy group, and Janet has joined us in this panel to talk a little bit about how the pharmacy profession can benefit from a decolonial lens. And Janet, when we spoke the other day, you mentioned a good amount of things in which the profession could benefit. So I'm wondering if you want to speak to your personal educational process, and then how with time you've been able to look back and say, wait, there's some things here that actually need to change if we're going to talk about an equitable field of pharmacy, a decolonial field of pharmacy. But there's also things that we need to already start mapping in the forward, things around how research happens, R&D happens, the role of big pharma. So tell us a little bit about your thoughts in regards to the pharmaceutical or the pharmacy, the profession of pharmacy, and the decolonial lens.
Thank you so much for your question, and thank you for having me here. It's been really nice to hear from students of other health professions and just everybody's perspective. So thank you so much for that. In my pharmacy school career, I think that so much of pharmacy education and just health education overall can benefit from immensely benefit from having a decolonial lens. I guess some personal anecdotes that I could give would be around how oftentimes I noticed that in the pharmacy school education that I had and in pharmacy system in general, our current economic and R&D models, for example, like you mentioned in our call, they work against the traditional knowledge systems and non-biomedical health knowledge that we have. And this is seen in the way that most of R&D models focus on conditions and diseases that pertain to the quote unquote global north, but also in the medications researched. So for example, in my lectures on natural supplements, they often label them as alternative without acknowledging the traditional knowledge systems and often centuries long health knowledge that was in place. And while we know that studied nutraceuticals and practices are constantly changing because they're a reflection of consumer interest and what people are interested in. So now there's a widespread interest in several of these. So as an international student, having grown up with a combination of many of these remedies with what is considered Western medicine, it was just surprising to see, the hierarchical nature that was employed, where it was first Western medicine and then everything else was clubbed into this term as alternative. So I think that should be highlighted because, you know, within the patient context and oftentimes the communities of color, it leads to this loss of autonomy of taking charge of their own health with, you know, remedies that their cultures or their communities consider as just vital to the health of their communities overall. So I think that this practice in general is ethnocentric at its core, and so that should be modified. Another thing, I believe that cultural sensitivity is commonly mentioned overall in health education, and this is an important step. But in addition, I think that overall challenging the worldview that, you know, our education is informed by the dominant narrative, and acknowledging that the dominant narrative, even within the global north, is viewed as a default position, and that informs guidelines. And I think that Lindsay mentioned this before, even in PT, for treatment guidelines and information dissemination, what is the actual evidence that we consider credible is often within or often viewed through that dominant lens. So it's really, really important to mention this to students overall. And then I think that another thing that I think that in pharmacy education and health education overall, oftentimes deals with clinical tools and risk scores and risk assessments. And many of these are algorithms that, let's say, correct for race based on, you know, that we recommend interventions according to US or, you know, Western clinical guidelines. And then this determines what treatment patients receive, and that has important implications in health outcomes. So we know that race is a political construct. So I think that pharmacy education and health education overall should move away from using race-based algorithms and treatment criteria. And a few universities have already accomplished this, so that would be important in my opinion. And the last thing, this also leads me to an important point in pharmacy education and health curriculum, which is a needed focus on being able to properly communicate information around racism, around bias and health outcomes in systemically under-resourced communities, not saying race is a risk factor for, and then actively having these conversations. Thank you.
Thanks for providing those insights, and I think that's very powerful. I just want to also highlight some of the things that you were mentioning when we talked the other day, and that might have not made your comments, but I did want to highlight that sometimes even the models, when applied R&D, right, will take quote unquote advantage of populations in the global south to do research trials, large research trials, right, and then those communities not necessarily benefit from those research trials and that exposure to that risk. And we've seen that even in the COVID pandemic. And Janet, you mentioned that in India, large clinical research trials were ongoing and within the pharmaceuticals and the different biological agents that were being tested. And then pharmaceuticals have not followed through with the distribution of vaccines in India. And we've seen the consequences of that play out in a very negative fashion as COVID-19 has broken the Indian health system. So there's also that we need to really speak of, because these are the future professionals that are going to be leading these trials, that are going to be leading these companies, that are going to be leading the conversation at a governmental level. And we really need to bring these things to fruition and make space for education in that regard. So I know we're a little over time. I leave with a lot of good notes here that I want to bring to the internal conversation we're having on Thursday. And to panelists, I just want to remind you that you are invited to participate in these thoughts. And I want to thank you all for this process that you've been engaged with in the last 4 weeks, in which you've been building up your insights and you're building up your different takes on this topic, and which is the culminating experiences today. So this feels like a culminating experience, and it really is for all of you. But what I want to say is, don't allow it to be the end. do continue to push this conversation with your faculty. And I really want to send a shout out to all of your faculty. I didn't mention Dr. Dania Kato from the pharmacy school that has facilitated this and will be joining us in a panel briefly. What will happen now to